JVD, not tracheal deviation.
Jugular vein distension?
Yes. It's a cardiac.
Is it stroke?
Not stroke. CHF. Yep, CHF. So we're checking for JVD. You're going to know JVD. The jugular is going to be sticking out like you're just going to be able to walk up like, oh, that guy's got JVD. Cool. JVD, you're checking for tracheal deviation. Now, tracheal deviation is a sign of what? Collapsed lung, tension pneumothorax, hemothorax, whatever it might be. The trachea actually deviates to the good lung. So you're going to know right away if it's deviated to the left, they have a right-sided lung collapse. Okay? That's an ALS situation. You need to get them out there soon so they can relieve the pressure and get the lung back up. So you've got JVD, we've got tracheal deviation. We're checking for stomas, which is going to be a hole in the neck. We're checking for subcutaneous emphysema, which is when you feel it, you're not going to see it on the surface. Right, it sounds and feels like bubble wrap. It's actually kind of cool. It's not a good thing, but it's kind of cool. Subcutaneous emphysema, we're checking for accessory muscle use. We're checking for medical tags. Missing anything? Am I good? Oh, we're still in the neck. Oh. Yeah, I'm going to, hang on a second. I'll go take that. All right, so don't forget, subcutaneous emphysema and accessory muscle use we're also going to see in the chest. So when I come down to the chest, I'm going to auscultate the lungs. I'm going to check for subcutaneous emphysema, accessory muscle use, sucking chest wound. Anything else?
Flail chest.
Flail chest, which is basically a collapse wall. A flail chest and paradoxal motion are almost go hand in hand. That is when you have more than 3 ribs broken on one side. And that side, when you breathe in, sucks down. You're going to notice it right away. What you want to do is you have to try and, they recommend, I've never seen it done, but they recommend using a sandbag to keep it where it is, so that way it doesn't suck down anymore. Because the more that you breathe and the side that has the broken ribs and keeps sucking down, those ribs are liable to lacerate a lot of things: liver, kidneys, spleen, whatever else is in this, on both sides of the body. I've never seen it done with a sandbag. I don't know why they recommend a sandbag. I don't carry a sandbag on an ambulance, for one. But so if they ever say flail chest or paradoxal motion, it's pretty much the same thing. So it goes pretty much hand in hand. Anything else in the list?
Barrel hoop test.
Barrel hoop test. We're barrel hooping again to make sure they don't have any broken ribs, because if you grab them down here, they're gonna, you're gonna know. They're gonna let you know if they have broken ribs. We're also barrel hooping the clavicles. We're checking for stability of the clavicles, because once your clavicle is broken, you're gonna know right away. It's a painful injury, number one, and you're gonna know. All right.
Literally downwards, so
Ooh. Screw that. Yeah, I bet. Who wants to do the abdomen? Anybody? Seriously? All right. Abdomen. If they have abdominal pain, where do you want to start your palpation? Furthest from the pain, right? All right, so we want to palpate the 4 quadrants. We want to check for eviscerations. We want to check for rigidity, guarding, distension. We want to check for implanted devices and stomas. If you are doing a exam at about the level of the belly button and you palpate a pulsating mass, what is it?
AAA.
What is a AAA?
Abdominal aortic aneurysm.
And do we go code 2?
No.
How do you treat an evisceration?
Sterile wet. Sterile wet dressing.
Now, everyone keeps saying wet. It's a moist. Make sure it's moist. You don't want to have a lot of wet going into the body cavity. Just moisten your sterile dressing. Place it on top of the organs. That's just going to keep the organs supple and wet, so that when they get to the ER and the OR, they're not all dried out and useless. And then you put an occlusive dressing on top, tape it down, and transport as gentle as possible because it's a very painful injury. I think that was everything for the abdomen, correct? All right. This is the easiest one in the world, so please somebody come up and do the pelvis. If you don't know the pelvis, I'm gonna smack all of you, except for the women, 'cause that's just not right. Seriously? There's like 3 things in the pelvis.
Barrel hoop.
Come on, Chris. Come on, Chris.
Vaginal bleeding.
And what else? There's one more. Priapism, vaginal bleeding, barrel hoop test, and what else? Incontinence. Okay, I swear to God, if nobody comes up through the extremities, which are just as easy. Thank you.
Yay.
Back loud. Alright, checking the, we'll start with the arms or the legs.
Doesn't matter.
Doesn't matter. Okay. Obviously check for hemorrhaging, but that's already done. And PMS, ankle bracelets.
What are
or
you forgetting?
before PMS?
Yeah, what's the first thing you should check on the extremities?
Oh, capillary refills.
Decap.
Check for breaks,
Okay.
deformities.
Deformities.
Yeah.
So should I just say decap BTLS?
No, all you're gonna do is you just walk up to the extremities. So the first thing I would do, I would check for instabilities.
And make sure there's no breaks or fractures.
Exactly. Then you move
Okay.
on to what?
PMS.
Okay.
Okay, and then from there, capillary refills. Should you say pedal pulses?
I don't know, part of the PMS.
Yes.
Show me how to do show me how to do PMS on the lower extremities.
You're gonna tell them, ask them to push, ask them to pull.
Okay.
Ask what toe you're grabbing, and then see if it's pain. Like if you apply pain, if they react to it, and then pedal pulses, and then I believe that's it.
Now, what if the patient has decreased strength on the left, but has okay strength on the right? What is that? What might that be an indication of?
Stroke.
It could be a stroke. Could be it could be
Or
anything
something-
with the brain.
Yeah.
Exactly. And that's something that is, I don't know. You guys need to start drilling this into your heads. Documentation is king, because if it's not documented, it didn't happen. And I know of an EMT that it didn't happen out here in California. It happened over in Indiana. They don't know how it happened. They don't know how the guy pulled it off. The guy was paralyzed already. Got into a car accident. Got ejected from the vehicle. Paramedics come on scene. EMT comes on scene. Put him in a brace. Put him in the C-collar. Put him on the backboard. But they don't document that they did PMS. Gets to the hospital. Oh, God, I'm paralyzed. The guy came from another country, so they didn't have his medical records. So they never knew he was paralyzed in the first place. Sues the EMTs, sues the paramedics, gets a huge sum of money. Documentation is king.
Like, how much did you get?
Are you already
got a lot of money.
paralyzed and then get a lot of money after?
So it does PMS on the uppers, on the lowers. Same thing pretty much on the uppers. It's going to be your grip test. Close your eyes. Which finger am I touching?
Okay, so you make sure that they obviously can't see it.
Right. Now, the one thing we are forgetting for PMS is what on both our upper and lower extremities? We've got pulse, we've got sensory.
Motor.
Well, your toes and fingers.
Okay.
All right. So that's basically your extremities. You want to check for PMS. You want to check for deformities. On younger children, you want to do cap refill. You want to do cap refill on people that have poor circulation.
Diabetic.
Right. Exactly. So the very last thing is if nobody comes up here to do the posterior, I'm just going to start kicking someone's butt. Because I swear to God, posterior is by far the easiest thing next to the pelvis.
You just roll them and check for the spine and the butt.
We're checking on the butt.
Incontinence.
That's it. And then flip your page, the very last box, again, has to be known verbatim. So the very last box for the primary and the very last box on the secondary. All right?